Welcome to Grand Rounds. Thanks for coming. This morning, Brian, Steffen, and I are going to give you an update of the research we do in our laboratory. We're going to talk about cardiovascular disease, risk-enhancing factors, etc. So for the first few minutes, I'll be walking you through, give you some background, and so no disclosure on what we do in our laboratory and why we do what we do, sort of the raison d'etre of our research and of our team. This will be followed by Brian, who will be talking to you then about describing in detail some of the work that has been published recently. So first, some background. Okay, we do cardiovascular disease prevention research. And following. So after Brian talked about the recently published papers, then I come back and I talk about the ongoing work, current work that's ongoing in our laboratory, which are done by other members of our team. Some of them are sitting right here. You all know Amy Carger. Amy Carger, all of you know. And also Sarah Nomura, who's right here. Sarah just joined our team last December, but hit the ground running and has been very, very productive. We also have Natalie Weir, who's a longtime member of the team. And still other people in my laboratory, some of you know, who is working with a long distance, such as Jane Zhao, who is a fellow in clinical chemistry, is now a faculty member at University of Texas Children's Hospital, but she still works with us long distance, as are many other people, faculty members at other medical centers. So what we do in my laboratory is basically looking at clinical laboratory measurements, be it lipids, lipoprotein, or novel biomarkers, and determine how useful are those biomarkers, singly or in combination, in terms of risk assessment of cardiovascular diseases. On the other hand, this type of thing is actually guided by official guidelines. So, for example, this was done by the National Cholesterol Education Program, which is part of NHLBI, which started issue guidelines, the Adult Treatment Panel, or ATP-1 in 1988, more than 3 decades ago, followed by ATP-2, ATP-3 in 2001. And then we are all waiting for ATP-4, but that never came, as the National Cholesterol, the NHLBI, decided to transfer this task to the American College of Cardiology and American Heart Association. So after a long waiting for ATP-4, finally, 12 years later, a new guideline appeared in the end of 2013, November 2013, this time by ACC and AHA. So this replaced ATP-3 as a new guideline of treatment of blood cholesterol to reduce cardiovascular disease risk in adults. So this is an 80-page document. Obviously, I'm not going to go into this. A major feature of this document is the appearance of what's known as the pooled cohort equation, or PCE. This is actually a risk calculator that you can be used to calculate the risk of any individuals. I think it's limited to age 40 to 79, and determine a person's 10-year risk. Okay, so what do we have to do to get that number? So we put in age, gender, other risk factors such as race, whether a person is hypertensive, diabetic, smoker. Then we put in 2 laboratory numbers, total cholesterol and HDL cholesterol. At the end of which, if you push calculate, a number will appear. So for most of us, for the majority of us, without going into detail, the number is 7.5%. So if your 10-year risk for an event exceeds 7.5%, then it is recommended that you be put on statin therapy. Below that, no. Is that absolute 7.5%? What if I'm 6%? What if I'm 8%? Should I be put on statin? Is there any flexibility? A little bit. At that time, family history, obviously, if you have family history, severe family history, that should be considered. 2 other laboratory measurements. LDL cholesterol, very high, greater than 160 milligram per deciliter, and a high sensitivity CRP of greater than 2 milligram per liter. These 2 are very easily treated by statin. Most statin will lower both LDL cholesterol and high sensitive CRP, which is an index of inflammation. Also, CT scan, which can be used to determine the coronary artery calcium score. If that score is very high, you're at very, very high risk. And also ABI, ankle brachial index, which is a screening test for peripheral artery disease, can also be taken into consideration. Okay, next slide shows what we were doing in terms of risk factors, apolipoproteins, lipoproteins. Two areas at that time. Lp(a), which is an independent risk factor for CVD. I think some of you may remember when one of my guests, George Tenosaris, came in December talking about Lp(a). apoB is a way to measure beyond the LDL cholesterol, the LDL particle size and particle number, and gives you more information than the cholesterol alone. Now, obviously, these 2 risk factors were not included in 2013 guideline. So what do? Well, we kept on working. So some of our papers published between 2014 and currently on Lp(a). We have 6 papers here. We also published 5 papers on apoB, so we kept on working. I had kind of the hope, I was pretty certain that at least Lp(a) might be included in any kind of updated guideline of the 2013 guideline. Less certain about apoB at the time. Well, fast forward to November 2018, exactly 5 years after the 2013 guideline, a new guideline appeared by ACCHA in collaboration with other societies like the Society of Lipidology, etc. Now it's called the 2018 Multi-Society Guideline. Now this is an even longer document, and it really is a much better, much improved guideline. This one is, instead of 80 pages, it's 120 pages. So 50% longer, a lot of great stuff in this new guideline. But I would talk about one major new feature in the guideline, which is the appearance of what's called risk-enhancing factor. Not risk factor, but risk-enhancing factor. This is a new terminology. In it, it's a fairly long list of risk-enhancing factors. Some have already appeared in the 2013 guideline: high sensitive CRP, LDL cholesterol, ankle brachial index. Others were in ATP3, were not included in the 2013 guideline: metabolic syndrome, high triglyceride, along with, of course, family history, and they include some new diseases. Some diseases are new to this guideline: kidney disease, preeclampsia, etc. So, but very importantly, we're very gratified that both Lp(a) and apolipoprotein B were now included in this long list of risk-enhancing factors. So Brian will now come up to tell you about some of our recent publications with regard to Lp(a). We're not going to talk about apoB. Brian is a senior research associate, has been with our lab for a number of years, has been extremely productive. So he'll tell you about Lp(a), atherosclerosis, and heart failure. Right.
Okay, can everybody hear me? Ish. So thank you all for coming this morning. I know we're a little pressed for time with the meeting right after this, so I'm going to paint some broad strokes, and if there's some concepts maybe you don't understand, feel free to email me or talk to me after, and hopefully I can clear those up. So first things first, I have no disclosures. Now, as Mike mentioned, a number of our studies, many of these were conducted in the multi-ethnic study of atherosclerosis cohort, or MESA. I just want to talk some of the background, its inception, and its composition. First, its primary aim was to examine subclinical cardiovascular disease and the risk factors that predict subclinical disease progression, as well as progression into overt CVD, but also kind of parse out the race-based differences in that progression. The first exam began in July of 2000. It's composed of 6,814 individuals that were free of overt CVD at baseline across 6 communities. And in terms of its composition was about 40% Caucasian, 30% African American, 20% Hispanic, and 10% Chinese American. So over the years, the Tsai lab has conducted a number of ancillary studies on specific biomarkers. Mike has mentioned a number of these already, but I think many of you know that Mike has been involved in plasma phospholipid fatty acids for 30 plus years or so. But we're also able to look at total free fatty acid concentrations, kind of a diabetes risk factor. Mike is looking more into those with heart failure. We looked at a number of methods to measure apoB, and then small dense LDL cholesterol, which I think is a really cool biomarker. It looks at the small dense fraction of cholesterol, so this would be the more atherogenic cholesterol particles. And then the subject of this talk is Lipoprotein A. So in terms of the specific papers, both of these were published in ATVB. The first is race-based differences in lipoprotein A-associated risk of carotid atherosclerosis. This was published in February of this year. And the second, LPA-related risk of heart failure is evident in whites, but not in other racial ethnic groups. And this was published in October of last year. And so this is our guy, lipoprotein A, or LPA. It's a very interesting particle. As many of you know, it's a subspecies of LDL. Despite this, it actually doesn't respond to statins. In fact, some studies have shown that with statin therapy, LPA can increase. Apart from this, it's a causal risk factor for coronary heart disease. And really the distinguishing feature of this is the apolipoprotein A component of it. So otherwise, it's just an LDL particle, and then it has this apoA covalently bound to apoB. So regarding apoA, interestingly enough, it's a homolog of plasminogen, but it lacks a catalytic domain. So you can see very quickly if it lacks that domain, many consider it to be anti-fibrinolytic and actually prothrombotic. Again, it's covalently linked to the apolipoprotein B. And apoA size is determined by its corresponding gene, conveniently named LPA. And it's really this apoA size that's a critical factor in determining lipoprotein A concentrations. So if you have a very large apoA gene, this should translate into a very large apoA protein. But it just doesn't work like that. If you have a very large gene, the likelihood of it getting translated and assembled becomes very low. So again, the larger the gene, the larger the supposed protein, but the lower the LPA levels. And the really take-home point here is that LPA is primarily determined by genetics, and it's primarily determined by this apoA gene. Now, if you're really interested in this and you want to get into the domains of apoA, there's a Kringle 4 type 2 domain, and the number of repeats, they go from anywhere from 2 to 40. There's been hundreds upon hundreds of studies looking at the apoA gene. So if that's your bag, Nathan, it's all you.
Looking at it now.
One of the genetic consequences of this, as many of you may know, is that black individuals have anywhere from 2.5 to 3-fold the levels of LPA compared to Caucasians, and indeed compared to Chinese Americans and Hispanics. And so this begs the very, I think, obvious question. If you have substantially higher LPA levels in black individuals, is this going to correspond to greater ASCVD development as far as LPA-related risk is concerned? Now, before getting into our actual findings, I'd just like to take a step back and talk about modeling a bit. Now, obviously, if you have these race-specific distributions, then you can't just take a quartile or a quintile approach, because then you're not comparing apples with apples, so to speak. So, luckily for us, there have been clinical cutoffs established for some time now. Historically, 30 milligrams per deciliter have been used across U.S. clinics and probably still are. And as Mike mentioned, in the new guidelines, they now recommend 50 milligrams per deciliter, but this level has actually been used for years in Europe now. So now we have 2 clinical cutoffs that we can look at, and then we can obviously examine it continuously because the distributions are skewed, do a quick log transformation, and so we can look at it in 3 different ways essentially. For the first study, the wow, that's a tough one. Atherosclerosis outcomes that we looked at were prevalent carotid plaque and then total plaque burden. Plaque burden, it's based on plaque scores, so it involves the number of carotid plaques that are in that particular vascular bed, so anywhere from 0 to 12 essentially. So just to orient you real quick, race ethnicities across the top, and then LPA exposures across the left-hand margin. And as you can see, the only significant associations we found were in Caucasians for this particular outcome. Fairly strongly significant, and what's interesting is that we found a race interaction at here with black individuals, and again here with black individuals. You can see the associations Hispanic are maybe approaching significance, the lower confidence interval at 0.99 and 0.98. And so graphically, you can see that individuals, or Caucasians I should say, with at the 30 or above cut point, have about a 16% increase in having carotid plaque, and those at the 50 cutoff, about a 20% increase in having carotid plaque. Just to orient you, I mean, 16 to 20%, is this meaningful? This basically kind of corresponds with male versus female, or being diabetic versus non-diabetic. So it's right up there with, common risk factors. So now we looked at plaque burden. Again, this is determined by the total number of plaques in the carotid arteries. And as before, the only significant associations we found were in Caucasian individuals. Should mention that a borderline association in Hispanics with levels over 50 milligrams or above. And again, a significant interaction was noted between Caucasians and blacks, regardless of the LPA exposure variable. And so just real quick graphically, regardless 30 or 50 was about associated with about a 0.5 greater plaque score in those individuals above those cut points. Just to, again, put these into context, you can see that these are just in Caucasians, obviously. LPA above 50 is about 0.55. Male versus female, diabetes versus non-diabetic, and being a former smoker versus a non-smoker, kind of all in the same ballpark in terms of risk of plaque burden. And of course, current smokers don't smoke. But this brings us back to kind of what's going on with black individuals. Here they are. They have a median score of 35.6 milligrams per deciliter. We're showing no associations at all. So it should be asked, are we simply using the wrong cut points? Should we be using 60 or 75, 100? Should we be using a race-based kind of quartile approach or a quintile approach? And so for the purposes of this talk, that's what I did. I examined these using the 60 milligram, 75, and 100 milligram per deciliter cutoffs, and these correspond to basically the top quartile, the top quintile, and the top decile. And as you can see, there's no associations were really evident there. Now again, that's an exploratory analysis. It really has to be vetted in another cohort. But so ultimately, we concluded that LPA was a risk factor for ultrasound-derived carotid atherosclerosis in Caucasian individuals. The borderline associations to Hispanic are equivocal and should be repeated. Again, the null findings observed in Chinese participants, because there was a lower number of these individuals, I think it would be appropriate to repeat in another population. And finally, I think really most interestingly is despite the higher LPA levels in black individuals, they just don't seem to be as vulnerable to LPA-related risk, at least in this vascular bed, and that's an important point. So moving on to LPA and heart failure. And of course, this is incident heart failure over the course of 11 years. We also had information on ejection fraction in MESA. So we're able to look at reduced ejection fraction or preserved ejection fraction. And this should look familiar. We only found significant associations in Caucasian individuals. Now, importantly, you might think, well, maybe you have a statistical power issue, but in terms of events, 118 in Caucasians versus 91 in black individuals. The rate was actually higher in black individuals. Chinese Americans are, at least in the MESA cohort, incredibly healthy, so there might be a power issue there. And Hispanics, again, the rate was about the same as Caucasians at 4.4%. And again, importantly, there were race interactions between Caucasians and blacks, as well as Caucasians and Hispanics. And graphically, okay, so I may be cheating a little bit here. The y-axis, the hazard ratio starts at 1. But the take-home here is Caucasians with over 30 milligrams per deciliter have about a 70% increased risk of incident heart failure. And for those with 50 or over, looking at about 90% greater risk.
Right. One question. So if you go back to your previous slide,
Yep.
it looks like there is increased risk in Caucasians, whereas in every other race group, it's actually a decreased risk.
Yeah, I'd be careful about it. I mean, those are pretty wide confidence intervals. So 24 to 131, 30 to 118, and it is a good point. So why would that be? I don't know. I mean, it's not a significant association, and that really, if anything, it should be replicated in another cohort. But it's a good point. Now, one of the most, I think, obvious mechanisms through which this might be happening is that, okay, well, we know that LPA increases and promotes risk of MI. We know that MI then promotes risk of heart failure. is this kind of LPA, it's promoting MI, simply kind of a mediator in the ultimate results with heart failure? And so what we did, we excluded individuals with MI, thinking, okay, that'll attenuate the results. But this isn't what we found. So the original results are on the right-hand side here, and then excluding MI on the left. And the associations were actually nominally stronger, which was a bit perplexing. Now, again, I'd be careful about over-interpreting this. Again, the confidence intervals are a lot of overlap between these. But yeah, that was unexpected. And the next thing we did, we looked at ejection fraction and classifying heart failure by reduced or preserved ejection fraction. Just as a quick review, and again using very broad strokes. Is Danny Dupre in the audience? So typical of heart failure with reduced ejection fraction is the enlarged left ventricle. You have a thin and weakened LV wall, and then of course you have reduced pumping ability. Now, for the purposes of this study, we set the cutoff at 45% of left ventricular volume. This is kind of an older way to do it. Now there's the mid-range heart failure and so forth, but there are issues with classifying it like that. So we stuck with 45. So anybody below 45% we classified as reduced ejection fraction. And on the right here, heart failure with preserved ejection fraction, you have a normal or small left ventricle size. Typical is left ventricular hypertrophy, and normal pumping capacity, again, 45% or above. And ultimately, it came down to, can we observe any differences in LPA-related risk for heart failure, classifying it using this system? And ultimately, what we found was, and again, we have heart failure with reduced ejection fraction, 47 events, heart failure with preserved ejection fraction, 54, and associations remained with the preserved ejection fraction, but were rendered non-significant with the heart failure with reduced ejection fraction. So we ultimately concluded that LPA is a risk factor for heart failure and heart failure with preserved ejection fraction in Caucasian individuals. The relationship was not dependent upon a previous MI. And ultimately, this kind of race-dependent relationships in LPA-related risk of heart failure may have implications in clinical practice. I mean, ultimately, what individual is going to benefit more from anti-LPA therapies than others? So, as with any cohort-based research study, I think we made some interesting observations, but we left open a lot of questions for future research. Of these, it has to be asked, I mean, okay, if this is actually true, and this can be replicated in other cohorts, is there some fundamental difference in LPA particles making them more pathogenic in Caucasians than in other races? There's a lot of usual suspects on this. LPA is a carrier of oxidative phospholipids. These, of course, are pro-inflammatory, pro-atherogenic. Are there differences in the amount of oxidative phospholipid content in apoA and the LDL particle that's associated with it? Lysine binding. So the Kringle 410 domain on apoA is known for, it has a bunch of lysine binding residues. Are there differences in those lysine binding residues between Caucasians and black individuals, or Caucasians and Hispanics? And finally, the antifibrinolytic prothrombotic effects, I should say putative prothrombotic effects of LPA. Again, can we, if we look at perhaps stroke or some other ischemic-related events, can we find differences between Caucasians and black individuals to explain differences in heart failure? And apart from LPA, are there differences in the vascular beds or the endothelial intermolares? So instead of LPA is the same, but perhaps its target is different. Is LPA more apt to accumulate in the arterial walls of Caucasian individuals, but not in black individuals? And finally, and this is unrelated to kind of trying to define those differences, those race-based differences. You know, right now they've gone from 30 milligrams to 50 milligrams in terms of a clinical threshold in the U.S. Is that appropriate? Should there be race-based cutoffs? Maybe 40 milligrams per deciliter would be more appropriate, maybe 25. But ultimately, as many of you know, there are trials coming up, therapies directed at LPA. There's oligonucleotides and antisense oligonucleotides, that is, PCSK9 inhibitors lower LPA like 40%. And I think those trials are probably in a better position to answer that question than really cohorts are. So, and with that, I turn it back over to Mike, and I thank you all for your attention.
Okay, thanks, Brian. So I continue with what we are currently going, these published results, and I want to show you, just to give you a preview of what's currently going on in our laboratory. Projects that led by different people, different members of our team. So I'll touch upon just two areas. If we have time, we can talk about future directions. But these are ongoing projects. Brian talked about heart failure. I'm extremely interested in heart failure. We are not just interested in Lp(a), but also other factors that play a role in heart failure. The subject of calcification, this is really very, very interesting. It's a major emphasis in MESA, the calcium deposition in coronary artery, extra-coronary artery, and I'll talk about biomarkers which play a role in calcification. So switch gear a little bit. We're going to talk about heart failure, but why? It's the leading cause of hospitalization, more than all cancer forms combined. It's a devastating disease. Some 50% of people with class 3, class 4 symptomatic heart failure patients die within 5 years. 300,000 deaths per year in the U.S. Probably the most important thing is it's becoming increasingly prevalent. One is for a relatively good reason, because we all live longer. 2, unfortunately, we have increased prevalence of risk factors. Hypertension, diabetes, obesity, as you all know. There's a mixed bag. We have improved survival rates from other cardiovascular disease, such as MI, valve disease, arrhythmia, with advent of the minimally invasive procedures for treating MI, replacing valve, etc. People live longer, but people who already have this cardiovascular disease are at higher risk for developing heart failure. So prevention is of prime importance, and really, for years I've been interested in MI, but this is really the transition now from MI. We need to transition to heart failure, because this is becoming a major problem. So first study looks at something that is a long-term interest, as Brian had told you, that I started doing fatty acids in 1982. The phospholipid fatty acid is where we can fractionate these fatty acids into individual fatty acids, omega-3, omega-6, omega-9, cis, trans, saturated, not saturated, etc. But has implications. Some of it is influenced strongly by diet, others not so much, subject to metabolism, de novo lipogenesis, etc. So this is a paper headed by Bob Block from Rutgers, an internist associate professor. He was interested in collaborating with us. He asked us whether he can work on our fatty acid data and heart failure. This is now in press as of, I think, last week in JACC Heart Failure. The finding is very simple, that the plasma omega-3 fatty acid, particular EPA, is associated with lower risk of heart failure. This is unlike the story of what Brian told you. In this case, it's regardless of ejection fraction status. So both HFpEF and HFrEF doesn't matter. Increase EPA, decrease risk. Next paper we're going to talk about, well, next project, it's not a paper yet, is a subject of free fatty acids. So what's free fatty acid? Free fatty acids basically non-esterified fatty acid. So fatty acid in triglyceride, cholesterol ester, phospholipid are esterified. You can cleave the bond and generate free fatty acids. So these free fatty acids is a byproduct of lipolysis, but it is an energy source during fasting conditions instead of glucose. So that's a good thing. The problem is that free fatty acid, when it's in excess, is associated with endothelial damage, ischemic myocardial damage, lipotoxicity, etc. So Sarah Nomura, who just joined us last December, is leading this project. She's going to look at free fatty acids and the biomarkers of heart failure, NT-proBNP, something we do in a clinical laboratory for detecting whether the patient has heart failure. She's also going to look at an intermediate outcome, left ventricular hypertrophy. Obviously, she's going to look at fatty acid and heart failure overall, and by the subtypes of preserved, reduced ejection fraction, and finally look at whether omega-3 fatty acid modifies this type of association. Some preliminary results already is that, somewhat surprisingly, that free fatty acid is very specifically associated with risk of preserved ejection fraction heart failure only, whether it's analyzed by total or whether we used free fatty as a continuous variable. And very strongly, these are preliminary results analysis. We have to do more further analysis. And in fact, at least at this juncture, and I don't know whether this would stand after more adjustment, that the free fatty acid is inversely associated with the reduced ejection fraction heart failure. So again, this is very preliminary, so we have to look at it with a grain of salt, but there's no doubt that it's mostly associated with the preserved ejection fraction. This is very interesting, you know. So what's the biology behind it? What's the mechanism? I mean, we can speculate a little bit. The preserved ejection fraction with left ventricular hypertrophy, with the hypertrophic cardiomyopathy, etc. Basically, free fatty acid could be working on the left ventricle, hypertrophy of left ventricle, or even work on the remodeling of myocytes. So in the nowadays that preserved ejection heart failure has become more and more prevalent. This is an important question. So we're looking forward to working more on it, and hopefully this paper will be published, this project will become a published paper in the near future. So what else is going on? We talked about heart failure, and the next subject matter that we're very interested is calcification. Okay, so a little bit background for those of you who may not be familiar with calcification. This is just calcium deposition in the formation of advanced plaque in the intima and the media of the walls of the coronary artery. So that's well known. What happened is about 25 years ago, it was possible to use CT, and at that time the electron beam CT, to detect and indeed quantify the amount of coronary artery calcium. And of course, once you do the CT scan, initially we just look at the coronary artery calcium, but we can also read, I can't, but a cardiologist can, the extra-coronary artery calcification, particularly left-sided valves and thoracic aorta calcification. Fact of the matter is, MESA, one of the primary goals of MESA was to determine how useful is a CT of CAC as a risk factor. And this is very, very important. I can't emphasize the importance of that. So this is because any kind of calcium deposition is considered, a person will be considered a higher risk. So if you undergo CT, if you have a CAC of 5, you're at worse off position. Conversely, if you're one of those lucky individuals who have no CAC, zero CAC, in MESA we find that zero CAC predicts zero CVD in 5 years, and very low risk in 10-year CVD risk, something like 1%, 1.5% at the most. So basically, you don't have to worry about cardiovascular disease for a long time if CAC says you have no calcium. The exceptions, people with diabetes, strong family history of ASCVD, and also smokers. So how do we use CAC? Well, CAC is now recommended for people with intermediate CVD risk, as calculated by the pooled cohort equation that I showed you. And the idea is to put people on statin, but then a lot of people don't want to be put on statin. Other people are intolerant of statin. Myalgia is a typical problem, and so these patients don't want to be on statin. So what do we do? So well, let's do a CT of a CAC. Okay, so we do a CT of CAC. So what do we do? Now we can reclassify the risk up and down. So for example, here's what I call intermediate high risk. Greater than 7.5% to 20%, these guys would have been put on statin. But what if you're statin intolerant? And you say, well, doc, I developed myalgia. It's quite painful. And so let's do a CAC. Okay. So if the CAC score is 0, we can withhold statin treatment from these patients. On the other hand, the PCE calculator sometimes comes out, and it just looks kind of suspicious to people because not every risk factor is taken into consideration. So you have people who are in the so-called low risk, but the doctor looks at it and says, this can't be, there's a lot of other risk factors. So what do? We do a CT of CAC. In this case, if your coronary artery calcium is greater than 0, then we would encourage these patients to consider statin. So very important. So for us, we're not the radiologist, cardiologist, so we like the biology. We like to know, what about laboratory measured risk factors? How do they interact with CAC? So a couple papers, a couple projects. This is a paper look at Lp(a) and calcification. This is led by Parvin Garg, who's the assistant professor cardiologist at USC. He contacted me wanting to work with our group. So this is one of the several papers that he's writing. This one's written up, ready to be submitted in the next week or so. Looks at the Lp(a) and calcification, both coronary and extra-coronary. What are the main findings? Main finding is that Lp(a) is associated with calcification of left-sided valves, aortic, which was found before by us, and mitral valves. Surprisingly, Lp(a) is not associated with CAC and thoracic aortic calcification, except in a subset of individuals. These individuals who experience rapid CAC progression of 100 units per year, and that's really a very severe condition. So this is very interesting, and we think this may explain the severe risk that we find in a subset of individuals whose only risk is Lp(a), and yet they seem to have very high risk and develop a CVD even very early in life. So this is I think exciting, and we want to follow up after this paper. Next is a project led by our own Dr. Karger herself. Among other things, she took time out to work on this paper. She agreed to look at homocysteine, a long-term interest of mine, which I haven't pursued for years, but we want to come back to look at homocysteine and calcification. As you know, homocysteine has fallen out of favor, but that doesn't mean we shouldn't look at it. Lp(a) has fallen out of favor for a couple of decades before people picked that up again. So we looked at homocysteine and calcification, both again, coronary artery calcification, extra-coronary artery calcification, and Amy found that the homocysteine is not associated with the left side valve calcification, whether it's the aortic valve or a mitral valve, but it is associated with coronary artery calcification. In this case, she also found the descending thoracic aortic calcification. And like Lp(a), it is associated with a rapid progression. A subset of individuals has rapid progression, greater than 100 units per year. So this is, people at high risk. So this is very interesting to me, because then we started looking back at the papers which has kind of discredited homocysteine as a risk factor. So one paper which is done by Joanne Manson's group, which is very good. They used B vitamin for 7.5 years to lower homocysteine, folate, B6, B12. For 7.5 years, 7.5 years later, there's no decrease in incidence of homocysteine is useless, right? No. Well, what they did, I think, by rereading these papers again, they recruited very high-risk patients, people who already had an event, and people who had 3 risk factors, people who are relatively old, not as old as me, but they're relatively old, 62 years old. So what do I think? These people already have established CAC and the calcification of valves and everything, by looking, they already had an event, and they're not young. So giving them B vitamin to lower homocysteine, the main effect of which is causing calcification, is obviously a futile process. It's not going to lower it because calcification is now reversible. So giving them B vitamin, now looking at retrospectively, shouldn't have worked, and it didn't work. So I think there's hope for homocysteine. Again, in the future, we're going to look into it. And this paper has been written up, submitting it in the next week or so after MESA approval. So what else is ongoing? Again, Sarah Nomura and I are collaborating with some cardiologists at UCSF. This time looking at calcification and heart failure. And not to take too much time, basically it says any kind of calcification is a risk factor for heart failure. These risk factors are additive, so one type of calcification has less risk than 2 types, and if you have all 3 types of calcification, you're at the highest risk of developing heart failure. This is a very preliminary analysis, and we hope this paper will be written up again in the near future. So just to take a couple of minutes of other ongoing projects, now that the so-called risk-enhancing factor, this phrase is now used by everybody, the REF is becoming a big deal. Long list of REFs. Okay, so how do we use it? How do we use it in conjunction with a PCE, in conjunction with CAC? Instead of just the doctor saying, oh, you have 1 risk factor, you have 2 risk-enhancing factors. what do you do? Is there a quantitative way of using it? Can we establish an algorithm? So Amy, Sarah, and I are collaborating with a couple groups of people at Johns Hopkins to look at ways of using these in a logical manner. There are other work going on. Jing Zhao, a former fellow, is looking at equations that's replacing the Friedwald equation. So there's an equation by Seth Martin at Hopkins, and Alan Romali, a friend, also has come up with an equation. And we're evaluating whether these equations can better ascertain risk than the use of Friedwald equation. But still, there are many other things going on, but these are some of the ongoing projects. So thank you very much. And we have other projects, but so the writing group: Amy Carger, all of you know, Sarah Nomura, Natalie Weir, Wei Hua Guang is a biostatistician who helped us with all the analysis. Parvin Gar from USC, Jing Zhao at Texas now, and Bob Block at Rutgers. Thank you. Questions? Yeah.
So the
Sorry.
association you see between LPA and CAC, is
Yeah.
that seen, is it more stronger in Caucasians as compared to other race groups?
I don't think so. I don't think so. We haven't really. I don't know if we have the power, but I don't think so. No.
It's not. I did it.
Leo.
Comment and a couple questions. So when Mike talks about his lab and paper was just accepted last week, another one's going in this week, they've published 23 papers last year, so that's kind of every 2 weeks. Nothing's happening. I just find it incredible. So a question for either of you on the little a intimal binding that you referred to.
Right.
How is that done, one, and two, since the lysine residues are implicated, has anybody looked at diabetics where there's non-enzymatic glycation of lysine residues?
I had considered the diabetes angle, but ultimately I think the way they look at this is through tracer studies, and they look at arterial accumulation. Now, how they get after lysine binding and how they would evaluate, that would be probably an in vitro assay, something along those lines. But I mean, I suppose you could, even look at the KIV or the Kringle 410 domain itself, and are there differences, run a GWAS, just like they did with the Kringle 4 type 2 domain, and then look at race-based differences. Now, so little is done with race, we don't even know, so much is done with LPA. It localizes the plaques, we know that. But it localizes the plaques in Caucasians. That's where all the studies have been done. They actually haven't looked at plaque localization of LPA across other races either. So there's a lot of kind of ways to tackle that question.
There's a lot of questions. You remember George Thanatos was here, and other people looking at the oxidized phospholipids and things like that. So that's ongoing. Yeah, John.
I know you said that LPA is primarily genetically determined, but I wanted to ask you to what extent does lifestyle changes, diet and exercise affect LPA? And secondly, to what in the recommendations that come out, to what extent is lifestyle changes recommended prior to statins?
So the short answer is that not much changes Lp(a).
Okay.
Not even drugs that's currently available, statins. Niacin can potentially lower this by 10-20%, but niacin has a lot of nasty effects. The newer drugs, drugs being developed, George talked about this, the antisense, Brian mentioned this antisense drug, most hopeful. Even PCSK9 at a high cost, it's not specifically at lowering Lp(a). Lifestyle probably would not do very much, unfortunately. Lifestyle, I haven't read every line or remember. in 120 pages of the new guideline. Lifestyle is always recommended very much. So the whole thing with this business of cholesterol and all that is that lifestyle helps, mostly helping lower triglyceride. You know, LDL has always been more problematic. You really have to be on a very strict diet to have any changes, effective changes. So yeah, I mean, it can be done, but it's not easy. Not on Lp(a). So yeah, Myron.
Yeah, hi. Mike, have you looked at acceptability factors for SNPs and so forth? People are typically making genetic scores of it nowadays, and look at that relative to the Lp(a) and relative to, especially the rapidly evolving form, refined subsets.
We certainly want to. I contacted a former colleague, Leo would know, Steve Rich, who used to be a member of our department, and we want to look at all the data that MESA has. You know, we have multi-omics going on in the lab in MESA. Honestly, it's a little bit of a too much of an undertaking for us to take on this issue. We would like to. I don't know if we can, but yes, I'm pretty sure there's a genetic susceptibility, as we have demonstrated here. You know, at least we think there is. At least it deserves us looking at it. But maybe Nathan's looking at. You know, it's we want to be part of it.
These screen repeats are a little bit harder. You can't get it from a GWAS very reliably. You have to look at the sequence data or specialized assay, right?
So we have the multi-omics that we do have whole genome sequencing, et cetera, et cetera.
Right, and so the top med data, which may be part of
right.
CHS, Eric, we now have the ability to look at that a little bit more carefully at scale, where we can look at tens of thousands of people. So hopefully my group and the structural variation work is trying to establish those things.
So yeah, we have to collaborate with other people to look at this type of thing. But I think our data provides stimulus for other people to, you know, look at it.
Does anybody else, these other cohorts, do they have these free fatty acids and LPA?
Free fatty acids, you know, free fatty acids is done by me mostly. So Eric has only the Minnesota part, 4,000, not 16,000. MESA, you know, we have. The other cohorts that we have will be cardia, but cardia is you know, younger individuals. So it's a fairly expensive technique. So any other questions? Well, thank you very much for coming.